So the need for LIRADS has come out basically because of inconsistent reporting and interpretation of the standard imaging findings, whether it's a CT or an MR. Ultrasound has not been incorporated as part of it. It's a decent screening tool, but it is far overrated. Far overrated. It's only a decent screening tool. So if today somebody is going to say, on ultrasound, I picked up an HCC, I'm going to say, wait a minute. You just come back to an MR or a CT, get it proved, and then we'll talk about it later. So it's a far overrated tool. Please don't use it as a single diagnostic criteria or a tool to actually call your diagnosis. More importantly, there's an absence of a standard lexicon, and there are variable terminologies which are used to describe a particular lesion. Some say HGDN, some say LGDNs. We have removed that and we are calling it cirrhosis-associated nodule. Again, there's a limited comparison of radiology data across a spectrum. So what exactly are the goals of LIRADS is to standardize the reporting structure and lexicon. It categorizes patients reflecting whether the lesion is benign, probably benign, or is an HCC. You reduce the variability in interpretation and reporting, and you give standard recommendations to the clinician. However, treatment may not go based on LIRADS. It has to be a clinical approach to finally form a particular treatment module. However, LIRADS gives suggestions and recommendations. So every MR which is done for a cirrhotic liver, actually at my place since the last 5.5 years, every liver MR for a cirrhotic liver underwent a LIRADS because we were part of the phase reading. But every MR with about close to about 800 MRs or plus, at least if I remember very accurately, 800 plus MRs all